This is the acromioclavicular compression test. This test attempts to displace the clavicle from the acromion while placing stress on the acromioclavicular and corticoclavicular ligaments. For this test, the patient is going to be sitting on the examination table with their involved arm hanging at the side, while I will be standing lateral to the patient with one hand on the posterior aspect of the acromion and one hand on the anterior aspect of the clavicle. For the procedure, I will be squeezing the acromion and clavicle together in an attempt to dissociate the clavicle from the acromion. A positive test would be pain at the AC joint, and this would imply a tear to or any kind of laxity or instability to the acromioclavicular or corticoclavicular ligaments. This is the Kennedy-Hawkins impingement test. For this test, the patient is going to be sitting with their arm in the anatomical position, and I will be standing lateral to the patient while holding on to their elbow. For this test, the elbow is going to be flexed to 90 degrees. The humerus is going to be abducted to 90 degrees, and it is going to be internally rotated until pain is felt or any scapular rotation is noted. A positive test would be any pain with motion, especially near the end range of motion, which would imply pathology to the rotator cuff group, specifically the supraspinatus or the long head of the biceps tendon. This is Jurgensen's test, which tests for the presence of pathology to the long head of the biceps tendon or a slap lesion. For this test, the patient will be sitting in a comfortable, relaxed position while I'll be standing lateral to the patient. For this test, the patient's elbow is going to be flexed to 90 degrees. I will be stabilizing the wrist proximal to the hand, and I will have two fingers placed over the groove of the biceps tendon. For this test, I will be externally rotating the humerus while the patient provides resistance. I will also be resisting any supination or elbow flexion from the patient. A positive test would be any popping or snapping in the groove of the long head of the biceps tendon, which would indicate laxity or tear to the long head of the biceps tendon, and any pain in the superior glenohumeral joint would indicate a slap lesion. This is the varus stress test that tests for the integrity of the radial-collateral ligament. For this test, the patient will be sitting in a comfortable, relaxed position. The elbow is going to be flexed to about 25 degrees. I will be standing in front of the patient, holding on to the medial elbow while also stabilizing the distal wrist. For this test, I will be providing a varus stress to the elbow to test the integrity of the RCL. A positive test would be any pain or laxity produced at the RCL. Any moderate laxity would indicate a disruption to the RCL, and any gross laxity may also indicate injury to the annular or lateral ulnar collateral ligament. This is Watson's test for scapholunate instability. For this test, the patient is going to be sitting with their elbow flexed in the position of what would be an arm wrestling competition. For this test, I'm going to be in front of the patient, ready to perform this test on them. The patient is going to also have their wrist in ulnar deviation. I will be applying a dorsal force on the distal pole of the scaphoid bone while also moving the wrist into radial deviation. A positive test would be any pain at the scapholunate articulation, which would imply a scapholunate dissociation.